So we're going to start with why this approach and why this software was developed in the first place. So the fact is that in the era when there was no chemotherapy for colorectal cancer, Dr. Makuchi from Tokyo University started operating liver metastasis. And they operate, and this is a series from 1980 to 97 when there was no chemotherapy available for colorectal cancer, not even for a few in Japan. And they had 15-year survivors by just complete resection of liver metastasis. And this thing is not working. Can I use something else? Yeah, okay. Can I use the keyboard?
Yeah.
Okay. So, and if you see the prognostic factors, whether it is unilobar or bilobar, whether it is whether you have a tumor-free margin or a positive margin, it did not make a big impact on the survival. What made an impact was the biological factors like CEA levels, lymph nodal positivity in the primary tumor, and the time to development of liver metastasis. So you see that even during those times, the things that he described still stand the test of time after all the chemotherapies and the immunotherapies that we have what to say. So the aim of the surgery then becomes is how to preserve enough liver volume and how to maintain the liver skeleton, by which I mean the Glisonian pedicles, the biliary system, and the outflow, which is the hepatic veins. And then it becomes a technical matter. If you can get the liver mets out while preserving this, the patient is likely to do well. Parenchyma preservation came into vogue and people started going from ultra-radical to ultra-conservative, and the reason is because several studies have shown that, including the 50-50 criteria, the MELD scores, etc., that majority of the deaths post-hepatectomy happen after a major hepatectomy, which is an independent prognostic factor in the outcome of the patient. And which is why the American answer to this was the two-stage hepatectomy, where they would do chemotherapy, then do a portal vein embolization, then the first stage hepatectomy, more chemotherapy, and then the second stage hepatectomy. But this strategy had a very high dropout rate, and it only increased an additional 7% of patients who would undergo the surgery for inoperable liver metastasis. And the dropout rate was quite significant, which is why if you compare the patients with intention to treat analysis, the advantage was not very significant. Also, the procedure itself, portal vein embolization, is not, it's a romantic concept, but it's easier said than done. It depends on several anatomical factors. It also depends on having a good interventional radiologist, the position of the tumor, and even so, then there will be always the risk of disease progression. And we are not even talking about the cost involved. Even the Western literature has talked about the additional incremental cost of this two-stage hepatectomy. So the German answer to solving this problem was to go for what we call as the ALPS procedure, where you do an accelerated, liver partition and second stage surgery very soon, because there is a significant hypertrophy of the remnant liver. But it is associated with very high morbidity and mortality. People thought that this was the learning curve, and they started maintaining a registry, but even in the registry, even after 800 cases, the mortality remained as high as 8%. And the reason is that although there is a significant anatomical hypertrophy, the functional hypertrophy is only 30%, which is why there is always the higher morbidity and the higher mortality related to liver failure. So what was the answer now? And the answer was given by this man, Dr. Guido Torzilli from Humanitas University in Milan. And what he described was a very simple phenomenon where you take an opaque organ and convert it into transparent organ using intraoperative ultrasound, and plan the liver resections before the surgery using a special software, which is what we're going to talk about, which is a Synapse 3D software. So it's a radiology workstation and a PACS system combined into one, using very simple intuitive techniques. We can produce 3D simulations of the liver, its vascularity, that is the Glisonian pedicles and the hepatic veins, and locate the tumor deposits in relation to these vascular structures. And then it becomes a technical matter of removing these tumors while preserving enough liver volume. The concept can be best illustrated with these cases. So I'll start with a very simple case up front. It's a 63-year-old male who had C. rectum with synchronous liver mets. received short course RT and chemotherapy, underwent a simultaneous resection, anti-resection with metastatectomy, developed a leak later on, then underwent an iostomy, underwent a closure later on, and 6 months later or 8 months later developed recurrence in the metastatectomy bed. It received microwave ablation, but CEA kept rising, and repeat MRI and PET showed that there is residual disease. So this is the lesion which we are talking about. It's in segment 7 in the previous metastatectomy bed. You can see it's quite peripheral, but because it has recurred in the metastatectomy bed, you would probably want to remove the whole segment. So you can plan it by marking the area which is supplied by the segment 8 portal pedicle, which is very easily done using the software, and you can see it. It's a 3D reconstruction of the segment 7, and you can replicate this by during surgery. And in the surgery, you know exactly where the vessels are located, the hepatic vein and the pedicle using ultrasonography, and you can dissect it in this fashion, preserving. You also get a report generated from the software about how much is going to be the resection volume, which is 120 cubic centimeter in this case, and which means that there is a 82% preservation of hepatic parenchyma, no sweat, no risk of liver failure. So this is a very simple case, and you would ask, why do you need a software for this? But what about this case? It's a 59-year-old male patient, rectosigmoid with synchronous liver metastasis, 7 of them. He received FOLFOX, bevacizumab, and then another cycle of FOLFOX, so 4 cycles of FOLFOX patient, and had 7 metastases post-chemotherapy with this distribution. You have a segment 7, segment 1, 8, 2, and 3. The number of lesions in segment 2 and 3 would, by standard criteria, mandate a left lateral segmentectomy, and by standard criteria, segment 7 and 1, which would leave less than 30% of liver volume behind. So it would have to be done in a 2-stage liver resection, which becomes too much. So how do you plan? You plan it by, if we use the vascular supply of each of these meds and mark out the area, this is what you get. This is a little confusing. If you fuse this into contiguous resection lines, you see there are 3 resection lines that are required. One involving segment 7 and segment 1 and going on to segment 8. Second is in the segment 2, the entire segment 2, because the portal pedicle of 2 was involved. And then there is a metastatectomy in segment 3. After modifying this resection specimens, we get a residual liver volume of 864 ml, which is 590 ml out of 864, which is 69%. So very safe liver surgery, and this is what was done, replicating the preoperative treatment plan. Segment 7 extending onto segment 1, you can see there between the right hepatic vein and the IVC. The right hepatic vein is preserved to preserve the venous drainage of 5 and 6. And the margin has been extended onto segment 8 to remove the 2 centimeter met in segment 8. This is the segment 3 metastatectomy and the entire removal of segment 2. You will also notice that the left hepatic vein was involved in the tumor, which is why it has been completely removed, but the software had shown that there was a segment 4 separate vein which had collaterals from segment 3, which is why we could preserve the segment 3, and this ensures that there is adequate liver volume. So another case, this is a 66-year-old male patient with CA rectum with colorectal liver metastasis, had 15 at the start, received FOLFOX cetuximab, he was RAS wild type. After chemotherapy, there were only 11 left, so there were 4 metastases which had disappeared on chemotherapy, but there were residual lesions on the PET and MR without any PET uptake. Now when you have this kind of a situation, often because there is no PET uptake, the discussion happens is, do we really need to operate? And we have enough evidence which shows that more than 85% of these lesions will have residual microscopic disease, so you want to remove all the 15 metastases. So we plan using the pre-chemotherapy liver scan. This is the model, which you can see there are multiple mets in segment 6, 7, 8, 4A, 2 and 3, and 1, which means that you have only segment 5 which is completely spared. If you see, although they are bulky, if you see the relation to the liver skeleton, the hepatic veins are spared. You can see those blue veins which are spared. You can see the portal pedicles which are completely spared, including the segment 5, 6, 7, and 8 portal pedicles, which you now, as the liver specimen inwards, you can see that if you can do an R1 vascular over the portal pedicles, you can preserve the inflow, which is the glycerol pedicles, and probably that liver segment can then hypertrophy. And of course, the segment 2 and 3 can probably undergo metastatictomy. So this is how the planning would happen. We see that a big chunk of the right liver would be gone, but you would still be able to preserve the part of segment 6, the inferior part of segment 6 and the inferior part of segment 5. But on this planning, we were not able to somehow save the segment 2. So that would have to be some modification during the surgery. The residual liver volume was 383 ml out of 1000 ml, which is 36% acceptable following chemotherapy. And this is the final specimen. Exactly the plan that we made on the right side of the liver. You can see the right hepatic vein is completely skeletonized. We have done a tunnel over the IVC, and you can see that is the middle hepatic vein, completely skeletonized. So we know from the modeling that all the metastases are above these hepatic veins, so we remove everything above that. And then you can see unfortunately the video is not playing too well. So on the left side, we were able to do metastatectomies and preserve both segment 2 and 3. The final histopath showed there were 16 lesions identified, only 15 on scans, 16 actually identified, with 10 having residual viable disease. So it is important to plan the scan on the pre-chemotherapy scan using the fulcrum MET so that we remove all the metastases at the time of surgery. This is another patient, a 57-year-old lady with neuroendocrine tumor, already had a segment 6 resection for 3 mets in segment 6. Now was detected with 16 metastases in the liver. Practically every single segment of the liver had metastases. And these are the multiple mets, so 17 metastases. And this is the final result after planning and after executing the surgery. The video. Okay, so the video is not playing. Apologies. So but if you could imagine that again the same principle is used, and you can see that the entire top half of the liver, what we call as the upper transversal hepatectomy, along with the wedge resection of segment 2 and 3 segment 6 has been performed. And after, because we have preserved the rest of the liver, there is enough hypertrophy, and the patient does not have liver failure, and in fact the entire liver hypertrophies. This was actually a follow-up scan which showed that the entire liver had hypertrophied after the liver. So this is another case, a 67-year-old gentleman with gist of the small intestine, having multiple liver metastases which were relatively controlled for a long time on TKIs, with now progression on the disease. And after, so the patient already had underlying baseline liver dysfunction because of NASH, and this is, so we could not do an extended left hepatectomy. So this complex liver resection was planned, in which we have preserved part of segment 2, part of segment 3, removed 4A, part of 4B, segment 8, part of segment 5 and 6. And you can skeletonize these vessels because you know exactly pre-operatively using the 3D model that this is where we are going to find the vessels. We use intraop ultrasound to identify those vessels and then do the resection based on these anatomical findings. This is, you can keep going, and I can keep going all evening about the increasing complexity of these liver resections. This is another patient who had a 38-year-old colorectal liver metastasis, young lady with multiple lesions in relation to all 3 hepatic veins. by the traditional criteria, absolutely not operable by either two-stage hepatectomy or an ALPS procedure. Using surgical planning and intraop ultrasound, we can identify which metastases are in relation to the hepatic veins. Then, for the surgeons in the audience, this is the R1 vascular approach, where you peel off the metastasis from the hepatic veins or the Glissonian pedicle. That's the left hepatic vein from which the segment 2 MET is being peeled off. It is important to take extra hepatic control of the hepatic veins before its junction with the IVC, so that in case there is some injury to the vein, you can use that to control the bleeding. But using R1 vascular, intraop ultrasound, and pre-operative planning using Synapse, you can execute these complex resections and ensure that the patient has an R0 resection. So this is the final picture of the same lady. This is the right hepatic vein completely skeletonized all around, and then resected, a small segment resected and re-anastomosed to maintain the venous drainage of segment 6 and 5. Segment 8 has been completely removed. That's the middle hepatic vein with a tunnel procedure performed to expose the IVC, because there were multiple meds in 4A and 8 which were in contact. And that's the left hepatic vein, which you can see, which I showed in the previous video being dissected. And of course the segment 5 wedge resection. So using this patient had 13 metastases in her liver. This patient had a one-stage surgery, went on chemotherapy in less than a month, and then had the second stage surgery for the colon metastasis. She is 1 year post-surgery and disease-free, for a patient which would have been otherwise considered completely inoperable by every traditional method of surgery. And all this is possible because of these advanced techniques. So this is the final specimen. You can see a big chunk of the liver is removed, but because we have preserved the inflow and the outflow, this liver is hypertrophy. I'll skip these slides in the interest of time. Another case, sometimes you need intraop ultrasound even for tumors like HCC. So this is a patient who had 78 years old, NASH, small 4 size liver with an 8 centimeter HCC involving the right hepatic vein, completely involving the right hepatic vein. So he was not suitable for a right hepatectomy because of his underlying liver condition, not suitable for transplant because of age and other issues. And this is the communicating vein between the segment 5-6 and the middle hepatic vein, which was identified preoperatively on the Synapse software and identified intraoperatively using intraop ultrasound and preserved. So the right hepatic vein has been resected, but not reconstructed because there is an alternative venous drainage. Are these kind of resections oncologically safe? Yes, they are. There have been studies done by the Humanitas group. There are several studies which have shown that R1 vascular or these kind of metastatectomies do not increase the risk of local recurrence within the liver, and in fact they have better survival results if we consider the intention to treat population. This is a study done between Humanitas University and Rene Adam group from Boujon, and they found that although the overall survival of these patients and the local recurrence rate was the same, if you consider the intention to treat population, which is on the right side, the extended hepatectomy, one-stage hepatectomy using intraop ultrasound has better survival results because there is a lack of fallout of the patients between the two-stage hepatectomy. Similar results with the ALPS procedure as well. And I would like to conclude with this thought that, what we are doing is actually not complex, it is simple. It is extremely hard to make a complex topic or a concept simple, but if you break it down into first principles and make the process reproducible, then we can move mountains. Thank you so much. Any questions? Thanks, Prashant. Thanks for
questions which always pop up when we do such bilobar resections in practice is that one, how much liver can we successfully save behind? That's a universal question. The second most important when we resect these multiple meds, like we said 13, 15, 18, is that when we leave behind that liver, the risk of a new one popping up,
So,
the short duration.
yes, so all this has been addressed by studies. We know that randomized trials are not possible in liver resections because it's impossible to randomize. But we also know from based on retrospective studies, and that's what I presented initially when you are not there, is that there are two ways of doing this. One is the traditional approach where you do the two-dimensional hepatectomies, the right and left, extended left, where the risk of liver failure is high because you are leaving behind very little liver. But if you modify these resections using these techniques, where you are preserving the inflow and the outflow, majority of the times the liver hypertrophies, and then you can extend it to innumerable number of complex hepatectomies by preserving the inflow and outflow. Second, to answer the second question, is the risk of local recurrence is the same whether you do a standard hepatectomy or whether you do these complex resections. The 5-year survival rate is 45%, which is not insignificant and is not achieved by any form of chemotherapy and targeted therapy. The best results that are achieved by chemo and targeted in liver metastasis is up to 2 years, which is 24 months. Here we are talking about more than doubling of that. So, since we are already dealing with metastatic disease, the question really is not about cure, the question is about long-term survival, and which is definitely better with surgery. Yes.
Good presentation, excellent presentation. So my doubt was, how do you assess the liver quality, like not the volume, how do you assess the quality, especially after chemotherapy?
Excellent question. So, there are several criteria which have been put across. You know, you have the ICG clearance, you have, of course, the liver volume. But we have to understand that for these complex hepatectomies, the radiologist cannot give you the residual liver volume. You have to plan the resection lines and calculate the liver volume yourself, because only the surgeon will know what is the resection lines. So the liver volume is one criteria which you get from the software. ICG clearance is what we use, and if the ICG clearance is good, majority of the patients can tolerate up to 70% liver volume loss. The third is, of course, the RP-LP score, which is fairly predictive in several studies for the risk of liver failure. But again, the idea is the volume. If you are preserving more than 40% of the volume post chemotherapy, which is possible in majority of the cases using parenchyma sparing techniques, I think the liver failure is never an issue. Thank you.
Thank you, sir.